Hi, so Paula and I are from Social Security Scotland. We're both in the Education and Development team in Health and Social Care Operations, and we're going to speak a little bit about what we are doing in terms of staff wellbeing, trauma informed wellbeing for our colleagues. So Social Security Scotland at the moment sits in that kind of perfect storm of one, that we work with vulnerable clients in the main, especially in the area that we work in disability payments. And we are in the middle of a cost of living crisis, and we are administering welfare benefits during that time to this particular type of client. So with that in mind, conversations that the staff or our colleagues in Social Security Scotland are having can be quite distressing, which you can understand. And for context, in Social Security Scotland, there's two separate parts, or not two separate, we're interlinked, but there's health and social care operations, and then there's client services delivery. So health and social care operations is full of registered health and social care staff, and then client services delivery is more kind of non-registered general staff over that side, but still client facing. So still having these conversations. Clients are discussing their conditions, restrictions in their lives, how that makes them feel. Hopelessness, suicide is obviously discussed a lot, family difficulties, and just so much more. We're really kind of hearing everything from people. And as health and social care professionals, we are keenly aware of the effects of primary and secondary trauma in professionals and the risks that brings both the individual and the organisation ultimately. And with kind of personal resilience and well-being being key, that's really what we wanted to look at, and really kind of what we were concerned about when it came to these staff that were having these types of conversations and maybe didn't have the same type of backgrounds that we had, or didn't have the knowledge about being trauma informed that a lot of us had already in health and social care. So for a bit of background, our local delivery colleagues, so our client services that are over the other side, the managers over there already started seeing that there was potentially gaps and potentially issues, particularly in training and trauma-informed support that they could provide. And they came to us, though, in possession of that knowledge, which was really, really helpful and I think insightful for them when they don't have the type of backgrounds that maybe we have. And they recognised that their staff and their colleagues were having these sometimes really challenging incidents, and that could be over the phone, but also face to face. And they were generating negative experiences for people, staff. So there were no trauma-informed debriefing sessions. There were obviously check-ins and discussions between managers and staff, but there were no trauma-informed debriefing sessions, and there was no de-escalation or any kind of training opportunities for them, where staff could openly discuss and reflect on the situations ultimately that they were experiencing. They were offered the opening doors animations, which are great, obviously, but it was offered, they were offered without context. And by context, I mean, specific to their role in this agency. It's a very kind of niche area that we work in, and there was nothing kind of context driven about it. It was all very much kind of, here's the animations, now you're trauma informed, and we recognised that it wasn't really working, or they recognised it wasn't really working and came to us about it. So the decision was made to design de-escalation training, including modules on, and this is already kind of all in the design stage and quality assurance stage at the moment, but looking at modules like crisis communication, behaviours that may challenge, debriefing, mental health awareness for managers, and it's all been developed through a trauma-informed lens. Stuart, that Lindsay was talking about, that led on trauma, he had a lot to do with the design of that training, but it was necessary to provide interim support in the meantime. We were really, really keen to make sure that people weren't kind of suffering or being distressed in the meantime. So we set up drop-in services, which I'm going to talk about in more detail, and actually they've been so successful, it may be that we continue with them going forward, whether or not we bring in extra things as well. They've been very, very successful. So our trauma-informed drop-in sessions, This was one of the first changes that we could make at some speed that would really kind of address the gaps that were being reported to us by client services. And the purpose and process, these sessions, they provide an informal setting for staff that have been affected to connect with other members of staff and access support. They are facilitated by trauma-informed staff. They run monthly and they use a mixture of in-person and online so that they're as accessible as possible. We offer two types of sessions. So we have a specific pilot for a subset of staff that we have over in client services who visit clients in their own home to help them fill in their application forms. So they're going into people's homes, which is a whole another thing. And then we've got our group that's just open to all Social Security Scotland staff. And the process of being referred into a session is the member of staff is involved in an incident or has a difficult conversation, and they speak to their manager. That would be their first port of call. When they speak to their manager, they agree together the best course of action for them. And the manager has a lot of different options, and it could be that initial conversation, that one debrief type conversation is enough, and the staff member needs no more. Or there's, we're the government, so there's a load of things that the manager can refer them on to. There's our wellbeing services in Social Security Scotland, which are great. We've got mental health first aiders. There's obviously we have an employee passport scheme, occupational health. But if the member of staff is not in need of immediate help, then the trauma-informed drop-in is a good opportunity for them to come along and reflect upon their experience. And they're referred to us through a booking system so that we can monitor referrals being made to us. We use a trauma-informed approach during the drop-ins, so we have trained facilitators who understand trauma dynamics. They can guide discussions and approach participants with empathy, understanding and sensitivity. The sessions focus on empowerment, choice and collaboration. They allow attendees to share as much or as little as they feel comfortable disclosing. They create a space where everybody that attends feels safe, they feel respected, and they feel free from judgment. And we're really, really clear about that when we start. There are kind of, I hate to say I sound like a teacher when I say this, but there are kind of ground rules, like every other group. And they create or they promote that kind of atmosphere of trust between each other, which is helpful between colleagues that are working in an area that they can hear distressing information. And the benefits of it that we've seen so far, peer support has been a huge bonus. Participants are connecting with other people who have had similar experiences, and it's really reducing their feelings of isolation when difficult and challenging incidents and conversations arise. Education, self-reflection, reflection on the incident itself, but also we are giving out resources when necessary. Validation. The attendees are receiving validation around about their feelings and experiences, and self-care as well. They're learning about self-care techniques, learning from each other what works for one person and what they could try, stress management. And there's going to be a wider evaluation. The pilot comes to an end kind of the end of October, so towards the end of the year we'll have a kind of wider evaluation and pull together all the data of how well it's gone. But at the moment it's all going very well. Now, we wanted to have some sort of a structure when we were setting this up, and we decided to kind of loosely use the distress brief intervention model because it was very, very similar to what we are doing here. So we know that trauma can contribute to the experience of distress, and if the brief intervention is a short, structured conversation with the aim of initiating a kind of positive change in a health topic, then the DBI model is really allowing us to respond to a colleague in distress in a kind of trauma-informed and meaningful way. So these structured conversations are often provided, we know in DBI, structured conversations are often provided by frontline staff who don't have experience in the health area. So we knew that our managers would be able to have these conversations if adequately trained. And we thought that, we really thought that DBI would be a good baseline for us to kind of kick off when we were designing our drop-in sessions. So we currently only model around DBI level 1, which is the immediate response to a person's kind of distressed presentation, because level 2 involves the structured referral to DBI community practitioners, and we're not there yet. And we're doing it's internally, and it's a kind of staff-based thing rather than with our clients at the moment as well. So we signpost on to our level 2, I suppose, would be that we're signposting on to our managers, wellbeing service, mental health first aiders, and these trauma drop-in sessions that I've been talking about. And that follows the structure of DBI, though, in that we are increasing the level of support that's required based upon that initial conversation with the staff member and in agreement with them. So that's kind of what our drop-in sessions look like at the moment. Now, we've got a lot, as Lindsay said, there's a lot going on in Social Security Scotland in terms of trauma, but we were trying to get down to what, in terms of staff wellbeing, what it looks like at the moment, and this is kind of what's going on. This is what is affecting staff wellbeing in terms of trauma just now in Social Security Scotland. So you can see we do have a lot. It's a lot to keep a track of and try and corral. So our key learning, what we know, is that in terms of staff engagement and participation, we know that the sessions are well attended and that staff participation has been at a good level. And I think that's, it's due, these are opt-in sessions. We're not forcing anybody to come along. It's not mandated, if you have had an experience or a distressing phone call that you have to come to a drop-in session. It's something that's discussed and negotiated between manager and staff member, and they decide whether they want to come along. Participation's been at a good level due to that. The impact on staff wellbeing and resilience, staff feedback, we send out surveys, and that's going to be part of the data, obviously, that we're compiling for the larger evaluation, but staff feedback's largely positive at the moment. Improve staff care through trauma-informed approaches. So managers are referring their staff to the drop-ins and to wellbeing services, and that's signalling, and they're very enthusiastic about it. So that's signalling a level of buy-in that's really going to be required going forward for us with all our grand plans. And the approach taken by us, we know that our approaches are trauma-informed due to the skills and experience of the team that's rolling it out. And the steps that we followed, we were collaborative. So working groups, we had a member of staff with lived experience lived care experience. We have a number of members of staff who would be using the service who had experienced distress within the agency due to their role. Managers, health and social care staff, there were a lot of us have kind of had input into these sessions. Staff training and awareness. So we are presently using the NES training. Our health and social care staff are at skilled level and our client services staff are at informed level at the moment until we really embed the roadmap and look at that again. And creating a supportive environment, which is, what do you say about that? It's a no-brainer, but it's really, really important, and it's really helped us move forward. Enablers and barriers. So our enablers leadership support has been really important to us, and our deputy director is a trauma champion, so we're very, very fortunate with that. So she's really been pushing it forward and is very interested in what we're doing, which has been great. Staff buy-in. I don't know whether I was surprised or not, maybe surprised, but people are curious about trauma and engaged and curious about the drop-in sessions and what we can do for them and how that might help them and their well-being and just their kind of day-to-day roles. So it's been good. I'm maybe a little surprised that people have been so curious about it. And flexibility in session scheduling, and I know that seems like a small thing, but in an organisation like ours, where people are on the floor speaking to clients, being as accessible as possible has really encouraged uptake. And barriers, and I think it'll be absolutely no surprise to everybody that works in a public service, but resistance to change and resource constraints. For us, resistance to change actually hasn't been at a significant level. I think now people are talking about trauma so much that it was more welcomed than perhaps, maybe when I first looked at trauma in the NHS a long time ago, when it first came out. I think here there was definitely kind of a welcoming atmosphere when we started speaking about trauma. And resource constraints, like everybody else, our biggest resources are people. Over in Social Security Scotland, budget hasn't so much been discussed yet, but definitely are people pulling people off the floor to attend training, to attend drop-in sessions. It all has a knock-on effect, obviously, on business. So evaluation, I said we're going to have this kind of wider evaluation, but until then we're still compiling kind of useful feedback data. Attendance and participation rates, one of the things we've been keeping an eye on. We monitor how many staff members attend the sessions regularly. High attendance rate for us would indicate kind of engagement and perceived value, bearing in mind, of course, that they're opt-in sessions. We assess how actively the staff members participate during the sessions, and are they sharing experiences, asking questions and contributing to discussions. The feedback surveys, we're collecting feedback from participants after each session, and we assess satisfaction, perceived benefits and areas for improvement. Self-reported outcomes, we're asking staff to assess changes in wellbeing, stress levels and coping mechanisms, and we'll be tracking those improvements over time. And qualitative insights, we explore their experiences with them, we speak about their coping strategies and any positive changes that have occurred. So lessons learned, helpful to know the importance of ongoing communication, especially in an organisation like ours where there's a lot of different moving parts and a lot of different kind of sub areas in the agency. Is really important that we're all continue to talk to each other. Balancing trauma-informed approaches or embedding trauma into the service with business as usual. Ultimately is really, really important, and finding a way of being able to do that comfortably for everybody involved, and that there's no extra stress being put on somebody because they're involved in trauma, because it just negates the whole purpose of what we're doing. Staff feedback and continuous improvement. We are testing and improving continuously. That's all we're doing. Things are working, things aren't working, and we're pulling them, but we're continually learning and tweaking things. And for others in a similar journey, so speak to other organisations. That's been key for us as best practice, sharing best practice and talking to people, and also encouraging people about trauma and to learn about trauma for their organisation. Adapting your trauma-informed practices to their unique context. So we're a different area than other places, so we've had to kind of look at trauma in terms of our roles and what we are going to be doing over here in Social Security Scotland, prioritising staff wellness and being open to learning and adjusting along the way. And to conclude, really, I know we're doing a lot in Social Security Scotland. It seems like we're doing a lot, but we've still got a lot more to do, and we're very committed to doing that. So we've just presented the options paper about how we're planning to embed the roadmap, or how embed trauma according to the roadmap. Our distress brief intervention learning has been put on our Learn Pro catalogues as we speak. De-escalation learning is coming to us very, very soon. We're waiting for that. We're going to evaluate our trauma-informed drop-ins, and we are also working with a number of different parties who are also working on it to change our professional supervision for our health and social care colleagues. It's going to be trauma-informed professional supervision now, so we're working with a number of people in that as well, just to make sure that both sides of the agency we're keeping an eye on, because it's important that we kind of stay standardised. So we continue to learn. We're going to be open and curious regarding feedback, new development opportunities, and there's still a lot to be done, but we are committed in Social Security Scotland to become a kind of truly trauma-informed service.